Good morning. I'm Kira, and I'll be talking about Colles fractures. Our objectives today are to learn characteristics, causes, clinical manifestations, tests and measures, differential diagnosis, and the rehabilitation process for Colles fractures. The Colles fracture is a complete fracture of the distal radius with a posterior displacement of the distal fragment, and it can come with dorsal comminution, dorsal angulation, dorsal displacement, radial shortening, and an associated ulnar styloid fracture. They are considered the most common type of distal radial fractures, and the fracture displacement and angulation often looks like a dinner fork, so it's called the dinner fork deformity, which you can see in this picture. And then there are two types, the stable and the unstable. The stable is present with minimal comminution, and an unstable is characterized by being comminuted with avulsion of the radial or ulnar styloid process. And then for the pathomechanics, we got a fall on an outstretched hand is the typical mechanism of injury, and it is more common in women than men, and they happen in young adults and the older population more often. They happen in older women with osteoporosis, and then younger people, it takes more energy because their bones are stronger, and it's usually because of high impact trauma. Next, we'll talk about the clinical manifestations. Some signs and symptoms include pain, numbness, tenderness, bruising, swelling, and you can see the deformity of the wrist. And then some functional limitations include decreased range of motion and the strength of the hand and wrist. Some important tests and measures are radiographs, so you can see it, the active range of motion, passive range of motion, MMT, testing grip strength, the Allen test, assess the joints above and below for other injuries, and CT scans can be used to look at the interarticular fracture pattern and for surgical planning if that's needed. And then an MRI is not necessary initially, but can help assess ligamentous or soft tissue injuries. Differential diagnosis, we got Smith fracture. This is often referred to as a reverse Colles fracture because it involves a volar angulation of the distal radial fragment and is caused by a bouche and a supinated rather than pronation. And you can see that it just happens opposite in this picture. The Barton fracture is another type of distal radius fracture involving a posterior anterior articular fracture resulting in a subluxation of the wrist caused by direct injury to the wrist or sudden pronation of the distal forearm. The Hutchinson fracture is an intra-articular radial styloid fracture that presents as oblique or transverse fractures to the radial styloid caused by direct trauma. A Galeazzi fracture is a fracture of the medial or distal radius with associated dislocations of the distal radial ulnar joint. And then you can do non-operative or operative management. So management of this fracture requires precise reduction of the fracture to maintain normal length of the radius. Stable fractures in good alignment may be managed in short-term cast, which can be removed after 6 weeks. A closed reduction and casting are chosen in most cases, but for more complicated cases, they may require an open reduction or an external fixation. So here we got the phases. For minimum protection, they should be no weight bearing or lifting for 6 weeks, and they have to wear a splint most of the time, except for when they're doing their exercises or just sitting there. They can start passive range of motion exercises and active range of motion exercises, including thumb opposition to the fingers, finger extension and flexion, wrist flexion and extension, and the tenodesis motion, and ulnar and radial deviation. And then for the moderate protection phase, they can do the active and passive still, and they can begin stretching it and mobilizing it using heat to help with extensibility. And they need to wear their splint during high risk activities, but they don't have to wear it at home or while they're sleeping. And then in the middle protection phase, which starts at 6 weeks, they go back to see the surgeon for a follow-up x-ray, and then they can start strengthening exercises such as bicep curls, shoulder abduction, flexion, and extension. And then they start with lightweight. They can squeeze a rubber ball for grip strength, flexion and extension of the wrist with the weight as well. And then a patient is encouraged to resume pre-accident activities that involve the affected extremity. These are some examples. We can see they are doing flexion, extension, and ulnar deviation. They got the stretches, and then some examples of strengthening exercises. The outcomes. Following the surgery and therapy, they can return to activities of daily living. They'll have restored function and restored strength. And then for an overview, the Colles fracture is characterized by a distal radius fracture with posterior displacement. It often occurs because of trauma on an outstretched hand, occurs more often in older females with osteoporosis and younger individuals. It is important to assess pulses and sensation, active range of motion, passive range of motion, and MMT. And it takes about 6 to 8 months to heal and get back to normal function. These are my references.
Go back to your slide where you're talking about the impairments and functional limitation. So, now, let's make this clear. So we want to make sure that we have a strong command of this, because you can see this on the National Physical Therapy Journal. All right? So, if I'm talking about signs and symptoms, I'm actually talking about impairments. So if I'm talking about impairments, in comparison to functional limitation, on this slide where it says decreased range of motion, would that be an impairment or a functional limitation? Is an impairment. So decreased range of motion is an impairment. All right. What about decreased strength of the wrist and hand? Is that an impairment or a functional limitation? So decreased strength, I'm just gonna say decreased strength right now. Decreased strength is an impairment, okay? So those are impairments. So terminology can throw you off if you don't have a strong command of it. So you need to know that. That lets me know to write a test question, several test questions, and put it in answer choices, impairments and functional limitations, and see if you can identify an impairment. Then let me know to write test questions intentionally on that, okay? And so to see if you can distinguish that. So those are signs and symptoms. Now typically, with decreased range of motion being an impairment, under the category of signs and symptoms, what would decreased range of motion be? A sign or a symptom? It would be what? Why do you say that? Because you can measure, okay? Symptom is more so like a subjective report, something that we typically can't measure objectively, something that we cannot measure objectively. It's just a report. So pain would be a symptom. We really can't measure pain objectively. We just have to go off of what the patient says, even if we use a pain scale. So we try to get an objective number with that when we utilize a pain scale, but it's still a subjective report, right? So therefore it would be a symptom. So strength would be what? Sign or symptom? Sign, because we can measure strength, okay? Now, let's go. Functional limitation. Now, so a person has decreased range of motion at the wrist, decreased strength at the wrist and hand. So what kind of functional limitation would these impairments result in? Say again?
Inability to eat.
Okay, so you can say inability to eat. Or I'm gonna say inability to use utensils with that hand, involved hand. So inability to use utensils. What else could be another functional limitation? Inability to write. Or difficulty with writing. What else could be another functional limitation? Inability to carry things, inability to twist or turn doorknobs. So inability to lift items. I'm gonna put e.g. Gallon of milk. Which will make grocery shopping difficult. Okay? Inability to turn doorknobs. You could think of so many things. Inability to catch, inability to throw with that hand. Those are functional limitations. Yes.
So basically, we're going more in depth with functional limitation. Like, for example, a sign would be, like you said, a decrease in strength. But say for somebody that's picking up something, or say can't do 25 pounds, would that be a functional limitation, or they'll move on to like a restriction?
That will be if they cannot lift a certain amount of weight, that would be a functional limitation. Now, in turn, because of a fracture or being immobilized, or when an immobilization is removed, when a cast is removed, the physician may assign or prescribe a restriction, like do not lift anything heavier than 5 pounds, or do not attempt to lift anything 5 pounds or heavier in this phase. So a restriction can be applied or prescribed by the physician. Yes. So a restriction is a little bit different, because a restriction is imposed on the person per se. So that's a little bit different than a functional limitation. Does that make sense?
Yes, sir.
Yes, Gavin.
But going back to signs and symptoms, so like I'm guessing numbness and tenderness would be a symptom, but what about swelling? Would that be a sign because you can measure the?
There you go, because you can take circumferential measurements. So with swelling, you can take circumferential measurements, and there should be an obvious difference when you compare one extremity to the other. So therefore, you can get objective measurements. Therefore, it will fall under the category of a sign. Okay. Yes. So good job. All right. So everybody clear on that? So that's why I asked you. I want y'all to be paying attention and engaging and asking questions, because that's how you learn. All right. Go to your differential diagnosis slide. This is a very important slide. This is a major component of your National Physical Therapy exam. The National Physical Therapy exam consists of 60% of the content. It's foundations for examination, differential diagnosis, and prognosis. That's 60% of the content from different areas. So from different areas, what I'm talking about, like cardiopulmonary, neurological physical therapy, orthopedics, a combination of all of those different areas is gonna make up 60% for foundations for examination, differential diagnosis, and assessments. So you need to know and convey the content on this slide. So make sure that you go back and read your books. Will you see questions on this on your midterm exam? You need to be able to differentiate amongst these. So Kira did a very good job with this slide. Just make sure you go back and read up on each of those conditions, okay? So you wanna go back and read. So she did a good job guiding me on that one. I think that's the only thing that I have. Anybody else before the next person? All right, excellent job, Kara.